Hello everybody, it's obstetric and gynecology made easy. Today we are gonna talk about caesarean section technique according to NICE and the American College guidelines, and comparison between pfannenstiel and the modified misgav ladach method. Abdominal wall incision. We have two types of incisions, transverse and vertical. The advantage of transverse incision: better cosmetically with less post-operative pain, adhesion, and incisional hernia. The advantage of vertical incision: quicker entry with less neuropathy, blood loss, and superficial hematoma. The disadvantage: we can reverse the advantage of vertical incision as a disadvantage of transverse incision, and we can do this for vertical incision. Vertical incision is indicated for cases with high risk of infection, like cases with morbid obesity. We have two types of transverse incision: pfannenstiel and Joel-Cohen for caesarean section. Joel-Cohen is the incision of choice because it's associated with less pain, analgesic requirement, blood loss, hospital stay, and duration of surgery. Abdominal wall incision, and let's start with skin. Pfannenstiel method. Pfannenstiel used pfannenstiel incision, which is curved 2 fingers above the superior border of the symphysis pubis, 8 to 12 cm long, that curve gently upward, smiley incision. Modified misgav ladach method, performed via Joel-Cohen skin incision or pfannenstiel skin incision. Joel-Cohen incision is a straight incision 3 cm below line between anterior superior iliac spine, a variable length of 15 to 17 cm. According to guideline and for your practice, perform a caesarean section with a low straight transverse skin incision using blunt and, if needed, sharp dissection for tissue layer. A higher incision may be required for those with a body mass index of 40 kg square meter or more. In some cases, a vertical midline incision may be necessary, like cases with large fibroid, uterine anomaly, and morbid obesity. Don't use separate surgical knives to incise the skin and the deeper tissue in caesarean birth, as it does not decrease wound infection. Escapable with electrocautery either is acceptable. The incision can be extended manually at angles up to 15 cm to provide good exposure. Subcutaneous tissue. Pfannenstiel method used sharp dissection. Modified misgav used blunt dissection by using scissors or finger to create a small pocket. For your practice, blunt is more favorable because it's quicker with less risk to cause injury to vessels. This is according to guideline. Here is superficial epigastric artery and vein. The superficial epigastric vessels can usually be identified halfway between the skin and the facial layer, several centimeters from the midline. If lacerated, this may be suture ligated or coagulated with an electrosurgical blade. The facial layer, the fibrous layer covering the rectus abdominis muscle, composed of 2 visible layers, external oblique muscle and diffused aponeurosis of internal oblique and transverse abdominis muscles. In the midline, this aponeurotic layer fused to create the linea alba. Muscle fiber of the internal oblique muscles are often noted below the amniotic layer of the external oblique muscles. Pfannenstiel method, sharp dissection with scalpel or scissors. Small incision is made in the midline, then extend it laterally. Modified misgav, blunt dissection by finger or a blunt instrument. If the patient complains post-operative of upper thigh pain that radiates to the vagina, the most likely nerve injury is the ilioinguinal nerve. Rectus muscle. The anterior abdominal wall muscles consist of the midline, rectus abdominis, and pyramidalis muscle, which are absent in 10% of women. Pfannenstiel method. Pfannenstiel method use blunt dissection. Modified misgav use blunt dissection. By using finger or blunt instrument to gently pull the muscles apart following the natural muscles fibers. Partial peritoneum. Pfannenstiel method, sharp dissection. The peritoneum is carefully lifted and incised using scissors or scalpel. Once a small opening is made, it can be extended to allow adequate access. Modified misgav opened bluntly using fingers or a blunt instrument at the upper level of intermuscular space and stretch in cranial caudal direction. According to guideline, blunt should decrease the risk of bowel injuries, bladder, or any other organ adherent to the peritoneum. In case of dense intraperitoneal adhesion, bluntly open to the upper abdomen to avoid the dense area and the scar tissue. According to random controlled trial, they are not significantly different in morbidity and mortality. Visceral peritoneum. Pfannenstiel method. Visceral peritoneum overlying the uterus is grasped with forceps, just above the superior margin of the bladder, and incised with Metzenbaum scissor. Misgav method, modified misgav, gently lift the visceral peritoneum to create small niche with scissors or scalpel. Enlarge the opening by bluntly dissecting with finger to decrease tissue damage and bleeding. Bladder flap. Bladder flap meaning cutting surface of the visceral peritoneum in order to isolate the bladder from the lower uterine segment. Indication: mnemonic flap. Indication of bladder flap: F for fetal head, when fetal head is deeply in the pelvis. L for lower segment, if not formed. This happens after 32 to 34 weeks. Bladder attached above the lower uterine segment after a previous caesarean section. You would better to avoid bladder flap to save time and reduce the chance of bleeding according to guideline. Uterine incision. First, recognize the position of the uterus prior to incision to avoid the damage of the left uterine artery if the uterus is dextro-rotated. Pfannenstiel method and modified misgav method. The lower uterine segment is incised with a scalpel approximately 2 cm above the vesico-uterine fold until the membrane bulge. Then extend the incision laterally with curved scissor using index finger as elevator in Pfannenstiel method. In modified misgav, the two index fingers are inserted to stretch the opening laterally. According to guideline, when there is a well-formed lower uterine segment, use blunt rather than sharp extension of the uterine incision decrease blood loss, incidence of postpartum, and the need for transfusion during caesarean birth. Patient with advanced or complete cervical dilatation, I mean second stage labor, the hysterotomy is placed relatively higher to avoid trying base laceration or unintended entry to the vagina. Indication for vertical upper uterine segment incision, mnemonic vertical, V for vascularity of the lower uterine segment if the vascularity is abnormal, E for entry if entry is difficult due to lower uterine segment pathology like myoma or placenta accreta, R if we need rapid delivery, T for transverse lie incorrectable, I for intrauterine fetal death, C for caesarean hysterectomy, cancer cervix and conjoined twins, A for adhesion which makes the lower uterine segment cannot be identified, L for lower uterine segment that is not well developed when expecting more than usual intrauterine manipulation. This incision is rarely performed at term as it is associated with uterine dehiscence and rupture in subsequent pregnancy. Fetal extraction. Inform women who are having caesarean birth that the risk of fetal laceration is about 2%. Use of forceps. Only use forceps in caesarean birth if there is difficulty delivering the baby's head. The effect on neonatal morbidity of the routine use of forceps at caesarean birth remains uncertain. For easy extraction of the head, make a spacious rectus incision, even if the skin incision is smaller. Use ecbolics and apply fundal pressure to aid the uterine expulsion of the fetus. Direct fundal pressure caudally in line with the uterine axis, not towards the opening table, like in the picture. Insert your hand gently, pressing on the baby's head rather than the lower segment. Allow the amniotic fluid to drain until the head is firmly impacted against your hand at the uterine incision. Flex the baby's head by locations occiput and gently pressing at the atlanto-occipital joint toward the sensibles. For deeply impacted head, push technique. Reverse breech extraction. An assistant apply gentle upward pressure on the fetal head through the vagina to dislodge it from the pelvis, and the primary surgeon use their hand to guide and deliver the head through the uterine incision. For floating head, rotation of the shin or occiput to the front and the application of forceps. Killing forceps application. Umbilical cord. Cord clamping is delayed more than 30 to 60 seconds in newborn who don't require resuscitation. Early skin-to-skin contact promotes breastfeeding. Placenta removal. Use uterotonic after the delivery of the infant. Use oxytocin 5 international unit by slow intravenous injection in caesarean birth to encourage contraction of the uterus to decrease blood loss. Remove the placenta in caesarean section using controlled cord retraction and not manually removal to decrease the risk of endometritis and bleeding. Changing the gloves after delivery of the placenta don't decrease risk of infection. Routine cervical dilatation before closing the uterus is unnecessary. Exoterization of the uterus. Pfannenstiel method uterus is not exoterized. Modified misgav uterus is exoterized. Exoterization or not are both acceptable and based on patient need and surgeon experience. Exoterization associated with nausea, vomiting, and more pain, and does not improve operative outcomes such as hemorrhage and infection. At the end, blunt dissection is more favorable for dissection and opening of the uterus because of less 5p. Blunt dissection is associated with less bleeding, blood transfusion postoperative, less bowel, bladder, and baby injury. Closure of the uterus. Pfannenstiel method. The incision is repaired into layer with continuous unlocked suture. This suggested the use of a delayed absorbable monofilament. Modified misgav. The incision is repaired in one layer with a continuous unlocked suture. This suggested the use of a delayed absorbable monofilament, monocreel. Use single layer or double layer uterine closure in caesarean section depending on the clinical circumstances. Note that single layer closure does not increase the risk of postoperative bleeding or uterine rupture in a sequence pregnancy. The effectiveness and safety of single layer closure of the uterine incision is uncertain. Perform two-layer continuous full thickness closure with delayed absorbable suture according to guideline. The first layer incorporates the myometrium and the decidual edge to achieve hemostasis. Second layer covers the exposed myometrial edges. For patients who would consider to lack, do two-layer uterine closure. Single-layer closure were associated with increased risk of uterine rupture than double-layer closure. Don't use locking suture unless there is arterial bleeding. Locked suture results in weaker scars, thinner myometrium, bell-shaped wall defect. Continuous closure with slow absorbable number 0 or 1 braided suture is recommended. According to guideline, baseball stage decrease exposed root surface and reduce adhesions in midline incision. Chromic gut with delayed absorbable monofilament and braided vicryl, no difference in maternal outcome. Placement of an adhesion barrier at the hysterotomy site is not beneficial. Abdominal irrigation associated with increased intraoperative nausea, longer operation time, longer hospital stay, and higher estimated blood loss. Closure of the peritoneum. Pfannenstiel method. Visceral and parietal peritoneum are closed with continuous suture. Modified misgav. Visceral and parietal peritoneum are left open. Neither the visceral nor the parietal peritoneum should be sutured to decrease postoperative fever and wound infection, decrease the need for postoperative analgesia and adhesion in the next caesarean section, decrease hospital stay, and decrease operation time. We can mnemonic these items in the word fast. No evidence for adhesion formation with non-suture. Advantage of closure of the parietal peritoneum is avoidance of distended bowel at the time of fascial closure. Closure of rectus muscle. Pfannenstiel method. Rectus muscles with 3 to 5 interrupted stitches with vicryl to 0. Modified misgav muscles are not approximated. According to guideline, no sutures. Natural reapproximation occurs, no need for suturing. If sutured, this results in pain on mobilization of the patient. but decreased chance of dense adhesion formation. Closure of fascia. Pfannenstiel method. Closed with continuous locked suture. Polygalactoline suture 1-0. Modified misgav. Continuous unlocked suture with vicryl number 1. Sutures are placed 1 cm from the edge and 1 cm apart. Avoid too much tension as it might cause strangulation. Just approximate for better wound strength. The benefit of using monofilament suture such as BDS to close fascial layer rather than polygalactoline like vicryl is to decrease the risk of infection. In case of midline abdominal incision, use mass closure with slowly absorbable continuous suture associated with fewer incisional hernia and decreased dehiscence than layered closure. Wide tissue bites more than or equal 1 cm and short stitch interval below or equal 1 cm, just approximate. Closure of subcutaneous tissue. Pfannenstiel method. Interrupted suture with vicryl 2.0. According to guideline, don't routinely close the subcutaneous tissue space in caesarean unless the woman has more than or equal to centimeter subcutaneous fat, as it does not reduce the incidence of wound infection. Use of superficial wound drain. Does not routinely use superficial wound drain in caesarean section as you don't decrease the incidence of wound infection or hematoma. Wound irrigation is not beneficial as it does not decrease the risk of wound disruption, infection, hematoma or seroma formation. Closure of skin. Pfannenstiel method. Skin may be closed with subcuticular suture. Modified misgav. Widely spaced suture, generally 3 stitches, with polyester or silk number 2.0, and the margins between the stitches are approximated with 4 Allis clamps for 5 minutes. Close the skin with subcuticular suture, decrease the risk of wound complication compared with staples, according to guidelines. I hope this helps. Please don't forget to like and share.